healthcare. So please begin.
All right. So my degree is actually in emergency care management, so I've combined aspects of the pre-hospital field and hospital-based care in order to, I guess, be prepared for both worlds because they do interact quite a lot. So I'll begin first with a couple of important thank yous, and there are a lot of people in the room here to support me for my presentation. So, to begin, my two faculty advisors, Mr. Crumperman back there in the back, if you'll wave, from the Emergency Health Services Department on campus, giving me the pre-hospital perspective and EMS perspective. And from the Department of Sociology, Dr. Anderson, right there in the front, who now works at the Centers for Medicaid and Medicare Services. My mother is also here, sitting next to Dr. Anderson. And my mentor, for the past year, I've spent a year at Shock Trauma, so my mentor, Vice President Karen Doyle, is back there in the corner. So, and the last two places on the PowerPoint slide up there, my junior year, I spent in an internship at an emergency services department, and this past year I've spent at our Adams Cali Shock Trauma Center downtown in Baltimore. So with that being said, now on to carrying confrontations. So as you look at the slide behind me, I want you to listen carefully to the following terms: heart disease, hypertension, surgery, liver failure, trauma, cancer. What's the first feelings that come to mind when you hear these words? Are you anxious? Are you nervous? Do they scare you? Do you think this is how patients feel in the healthcare environment? I believe so. How many of you, by show of hands, have felt this way in the healthcare environment within their patient-provider interaction? So you're pretty much everybody in the room. So with that being said, I chose to investigate the healthcare system, particularly the patient-provider relationship and the aspects of crisis. Before doing so, it's important to make a distinction between healthcare and healthcare. And you think it's the same word, but it's not. Healthcare, when it's joined together, is the actual system that you access. It's the social institution. And healthcare, when it's separated into two terms, is the actual patient care that you receive from a practitioner or a provider. And there are four main reasons to access the healthcare system. Number one is for prevention. So if you just go for your yearly checkup to the doctor. Secondly, for non-emergent care. So if you go, say you get a cold, you're sick, you go to a clinic. Emergency care, if you're in a car crash, you break something, you need to go to the emergency department. And the last reason is for rehabilitation or recovery reasons. So those are your basic outpatient services. If you go for physical therapy, counseling services, anything to return you to a functioning level of life. But all four of these reasons end in some type of provider-patient relationship. And within that provider-patient relationship, there are differing levels of anxiety and crisis. So I picked three research questions. The first one being, how is the provider-patient relationship established? How can crisis be diminished within this relationship? And what is the necessary skill set to sustain the relationship and limit the levels of crisis? To do so, I picked four main areas of concern when I did my literature review. The first being, what are the current definitions of crisis in the provider-patient relationship? The second being, what do my different disciplines define crisis as currently today? What are the available interventions? Is it something that's actually physical? Is it something that's said? And how are they evaluated? And lastly, I evaluated what are the necessary skill set for success of both the relationship and limiting crisis. And I accomplished this through an extensive literature review and patient case studies. After doing so, I went into my disciplines. And so the three disciplines that I chose for the foundation of this project were health as a subset of biology, psychology, and sociology. Health sees the patient-provider relationship just as that. It's a paradigm. It's something that exists. It's something that's necessary to happen. It's what needs to happen for you to get a diagnosis and then receive an intervention and get better, get healthier. It's based on medical practice and empirical facts, and so if it's going to add to the overall value of the patient experience or make the patient better, then it's going to be done. If it's not, then it's not going to happen. The other aspect is that there's a level of indifference in the healthcare environment to crisis. It does recognize that it's there, but oftentimes the signs and symptoms overshadow the recognition of crisis and the assessment of crisis in the doctor-patient relationship. Psychology, on the other hand, sees the paradigm as an actual relationship. It's an exchange between the provider and the patient, and it goes back and forth. They take different roles of being dominant and subordinate, and there are emotions attached with this relationship. So this is where the concept of crisis really gets defined. And since there are emotions attached, our behaviors are conditioned. Psychology views the relationship as something that we learn based on taking cues from the other person, and it's more of an individual intervention rather than a community-wide intervention. Lastly, sociology sees healthcare, it's a social institution, so it's something that we learn by being a member of society. We learn how to act as a patient, we learn how to act as a provider by what our cultural values and beliefs are. And that automatically determines the symbolic interaction between the provider and the patient. And the other thing that sociology brings into perspective is ethnicity, race, gender, and socioeconomic status all impact the eventual development of this paradigm. So that being stated, there are 3 integrative strategies that I used to settle the conflicts between the disciplines of health, psychology, and sociology. The first being redefining the patient-provider relationship, making it more, using the phrase, an active interaction rather than a relationship or a paradigm. And an interaction means that there are 2 roles. You either play the role of the patient or you play the role of the provider. And it also needs to include both individual and societal values in order for it to be a success. The second being extension, REPCO's extension for crisis recognition and assessment. The idea of crisis comes from the healthcare field, but it's not limited to the healthcare field. Psychology also views crisis as important, and so does sociology, except it's seen in different lights. Psychology on the individual level, and sociology sees it on the community level. And so it needs to be extended to more than just a community level or an individual level, but that crisis can happen at any time, on any level, and it's necessary to address it. And to combine both the redefinition of the relationship and the extension of the concept of crisis, I used Newell's concept of the comprehensive perspective, which has 2 parts. It has an educational component, and it also has a practical component. The educational component would be to educate our practitioners, our providers, and also our patient population on the importance of the relationship and kind of changing the cultural viewpoint of what the expectations of the different roles are. And the practical application of it would be to actually create a model, which you'll see in just a second, to be used in the healthcare setting in order to help patients and providers develop a better relationship in order to limit and diminish the levels of crisis. So that being said, this is the model that I have created, summarizing principles from sociology, psychology, and health in order to move a patient and provider along the continuum of care to return them to a quality of life. The purpose of the model, as stated above, is to diminish crisis in the provider-patient relationship. So if you can imagine, the arrow is kind of what parallels the provider-patient relationship. So you have to go through these different stages in order to get to a sustainable relationship. The first 2 stages, communication and therapeutic rapport, come from concepts from sociology. So communication is basically how we learn how to communicate with others. It's something that we learn, socialized into doing. Therapeutic rapport is based on the communication between the patient and the provider, and it needs to be based on the values of both parties, and that's also a sociological concept. The next 2 steps, 3 and 4, empowerment and resiliency, come from psychology. It's basically a mindset. Do you have the coping mechanisms? Can you be adaptive? Can you be flexible? And can you be empowered to actually make decisions in the relationship, both on the patient side and on the provider side? And the last step is recovery, and that's the step that comes from the healthcare perspective. And recovery is kind of hard to define because everybody has a different quality of life when they come out of a crisis situation, even if it's as simple as having a cold and it kept you out of school for a week. So it's kind of taken on different levels, but everyone that goes through the continuum comes back to a quality or a function of life at some time. Another thing about the model is that a skill set also kind of parallels it. So patients and providers all need to be able to communicate and be empowered on both sides in order to kind of exchange the role of being dominant and subordinate back and forth. So this is the practical aspect of it. This is the practical application of my integration. And last but not least, After taking this model and kind of testing it while reading patient case studies, some of the implications I've found are, first, that prevention instead of intervention. And it kind of sounds silly to say it that way because you're always going to need intervention, there's always going to be emergencies, but there are many ways to be proactive in the patient-provider relationship, and many ways for a patient to feel empowered enough to speak up about their care and to actually learn about the care that they're receiving and to feel like they actually belong in the process of moving them back to a quality of life. The second is the new skill set, both for patients and providers, that we need to change societal, cultural values about what we believe the patient-provider relationship is, and also the skill set to communicate. I mean, that's a very basic skill, but some people just don't know how to do it well. And the last part is just the lack of the definition. By redefining the doctor-patient and provider-patient relationship, it's given me the capability to come up with a model to actually implement in the healthcare setting. One of the particular limitations I do have, I've recognized I wasn't able to take any educational courses while here at UMBC, and I believe that in order to bring this model into kind of a curriculum perspective, I would need to explore some educational perspectives. And in conclusion, the two directions I would like to take the model that I've just shown you is, first, to be able to test it in the pre-hospital setting, compare it to the hospital-based setting, and the second is to eventually develop a curriculum after I have some educational components.
Sure.
More of a comment rather than a question. Thank you for providing that great materials. And I think if we're speaking of creating your own jobs, you've really nailed it, since the HHS just basically enrolled exactly what you're talking about, a partnership with patients, which goes along with not necessarily prevention, but secondary prevention. Once people come in with a crisis, how does the healthcare system, not just one provider, kind of go along with that? So it's not, and when we make this kind of comparison between like social crises, natural events and things, it's much different than the medical crises that unfortunately many of our people in this country have to experience over and over again because of that lack of continuity that you mentioned. So bravo. And I think if you do some of the training, because 80% of the doctors polled said that, you know, readmissions are a problem, but they don't know how to
what to do about them.
So training the providers, I think, is key.
One component you did not put up there, unless I missed it, was time. And I think sometimes practitioners have the goal to really work with the patient. But, you know, they've got it every 10, 12 minutes, every 15 minutes. They have to do certain things. And I think it's that system sometimes that is a challenge, and I wonder if you address that in your work.
I did address it in my paper, that providers, because of the way the healthcare system, the actual social institution of healthcare is set up, and insurance and all of those things, and unfortunately, unless the system changes, I don't know if we'd be able to extend the amount of time that you spend with your provider, but it's something that I mentioned that is a necessity in order for this model to be successful. There's no possibility that you can do that within a 10 to 12 minute time frame. So, yeah.
I had a couple questions. First, was this, in your thinking, was this primarily the physician-patient relationship, or does this apply to other healthcare providers along the continuum? And then I sort of related to that, I was interested in your thoughts on how you would construct the test of the model.
Well, this is made for providers along the continuum. I think that it's a little general in respect. I know you're asking about pre-hospital providers, I'm guessing.
No, not just, but yeah.
Yes, in particular. And I think that because the environment's different for pre-hospital providers, it's almost always an emergency, and even in transport care, it is a little bit different. I think that it could be abridged to say something that could be developed over time, but not necessarily immediately in pre-hospital providers, so I would like to implement it in a hospital-based system first. And your second question was?
The question was, what were your thoughts on how you would construct a test of the model?
I guess it would be more of a comparison about providers that did receive the curriculum and other providers that did not.
Okay, before and after kind of comparison.
Before and after, yes. And then after that, further along, I would want to test the pre-hospital environment versus the hospital-based environment and the continuity of care when you hand off a patient.
All right, Lauren also has some other distinctions that we would like to acknowledge today. Carrie?
Lauren is graduating with Interdisciplinary Studies Honors. You get to wear this cord at graduation. Congratulations. And she's graduating cum laude.
That means she will have a nice gold sash when she walks across the stage. So congratulations and thank you for your